Hello, and welcome to Northfield Medical's presentation entitled Save Money, Save Stress, Auditing to Prevent Damage to Surgical Devices. My name is Michael Matthews. I am the Director of Clinical Education and Training for Northfield Medical. And today we're going to show you how to use our Damage Prevention Audit forms to identify places where you can save money on preventable damage. So today's objectives are to explain the need for the auditing process. We're going to identify common sources of preventable damage to flexible endoscopes. We're going to describe best practices for preventing damage to flexible endoscopes. And then we're going to suggest a strategy for developing an ongoing quality improvement program to prevent damage and then lower those repair costs. So first off, let's talk about auditing itself. Why should somebody audit? And I know auditing is one of those things that nobody really gets that excited about, but it is critically important to a process improvement project. And even AAMI ST79 suggests that performance measures for problem investigation should include, among other things, instrument and equipment damage or failure. Now, instrument equipment damage or failure tends to represent a massive amount of money from any particular facility's repair budget. And we'll be using flexible scopes kind of as our example project that we're working on. And if we look at flexible scopes, the average price for a repair is around $2,000 each time. Now, that's an average over a pretty wide range. So there's a lot of repairs that could be less than that, and there's a lot of repairs that could be significantly more than that. But generally speaking, over the course of about a year or so, if you were to average out all of your flexible scope repairs, you're planning on spending about $2,000 every single time that scope is sent out. And it could be more depending upon who your repair vendor is. So as we'll see, because those numbers are so high, little incremental improvements in preventing damage can total up to a significant amount of money very quickly. And then you can take that money that you're saving from preventing the repairs in the first place and then roll that into other things that your facility needs. For example, increased stock. And one of the most important things that we want to talk about is taking a more proactive approach to quality assurance. If you are following more of a reactive model to quality assurance, that means that you don't know if something is broken until the OR or the endoscopy suite calls you and says, hey, we're in the middle of a procedure and this scope isn't working. The problem with that is that at that point, it has already adversely affected a patient. Now, that could be an adverse reaction that leads to something like a surgical site infection or some other adverse outcome, but even at best, it's raising the stress level of the people in the room, including the physician, and it's leading to increased time under anesthesia for that patient. Now, both of those things have been shown to lead to additional adverse outcome potentials. So proactive approaches to quality assurance are far safer for patient care than a reactive approach. And that's why we titled this presentation, Save Money and Save Stress. If you take this proactive approach, you are very likely going to end up identifying where damage is happening, how you can make those improvements, and that's going to lead to less money. But even if you don't care about the cost, the money at all, think about your stress level. For most frontline technicians or OR staff or endoscopy staff, one of the most stressful things that can happen is not having enough devices for the procedures that are going on. Now, that stress level can and has been demonstrated to lead to a higher likelihood of making mistakes, and not to mention that stress just makes you miserable. Improving our processes to help prevent damage will do more than just save money. It can save you a lot of stress and a lot of potential mistakes made for those patients. So that's why we created the Damage Prevention Audit tool. Now, these are free. You do not have to be one of our customers. These are available for download at any time, or you can message us and ask for a copy. We'll be more than happy to help you out. These are available for anyone. Now, we have audit forms already created for flexible endoscopes, rigid scopes, power tools, and video cameras. Now, like I said earlier, we will be using the flexible scope sort of as our example work through. But what we really want is for you to see the example worked out, maybe do one of these projects on your own, and then use what you've learned and then apply it to other areas. And it could be an area that we've already created a checklist for, but it could even be an area that maybe we haven't created a checklist for, something that's unique to your facility. And one of the reasons that we created this checklist is after working with hundreds of hospitals, we have found that all too frequently, damage is not really understood by the hospital staff at all. It's kind of looked at as something that just happens randomly. Nobody really knows when it's going to happen, how it's going to happen, how it did happen. It just happens. And it's kind of accepted as just a difficult part of life in healthcare. And it doesn't have to be like that, because damage in most cases, in fact, our research has shown upwards of 80% of cases, it's coming from flawed processes. And those flawed processes almost always have something to do with care and handling. And if we can identify where those specific areas are in your healthcare facility, that will give us our roadmap for improving those processes and making real, tangible improvements. So let's begin working through our example. And like I said, we're going to use the flexible endoscopes. We're going to work through that checklist, and you might learn something about care and handling as we're working through this process. Now, we begin our audit in the OR setup. There's nothing that says you have to begin your audit process here in the OR. You could begin with sterilization, you could begin with inspection, you may begin with decontamination, whatever makes the most sense for you, but we started it with the OR setup. And the reason we did this is because this is the last opportunity that staff have to identify those early warning signs before they affect a patient. We really want to see staff visually inspecting and function testing prior to the physician and the patient entering the room. And there are some very quick, simple checks that you can perform that will give you those ideas of whether or not a scope is going to function properly for that physician for the sake of that patient. You can check things like the angulation system. You can also look for early signs of damage like buckling in the insertion tube, like is in the picture example on the right hand side. If you see those things, the scope may at first glance work just fine, meaning that you plug it in, you get an image, but during the procedure itself, that physician is not going to be as satisfied with the performance of that scope, because those are all indications that something is going wrong inside that scope and it's not going to perform the way that the physician needs it to. Now, again, we want to find these problems before they affect the surgeon and the patient. And I'm sure everybody who's hearing this has probably been in the room when a device is not functioning the way the physician needs it to, and the stress level in that room goes up. The physician gets frustrated because the scope is not performing the way that they need it to. That stress then gets kind of pushed into the technicians and the nurses in the room, and of course then they have to go get the reprocessing staff to find out if another scope is available or how quickly they can have another scope turned over. And that stress just kind of cascades through the whole system at that point. And again, that increase in stress is what leads to an increase in mistakes. And so if we can prevent that stress from ever occurring by just simply checking a few things before the patient comes into the room, that really is the best thing. Now, one of the most common questions that we get anytime we present this information is, what do we do about damage that is caused by the physicians? And I know everybody kind of wants to jump to that really quickly because there is this perception that all damage is caused by the physician. It's not, but we do have to be mindful of the fact that most physicians, in fact, I would dare say almost all physicians, have never received any sort of proper care and handling training as part of their medical training. Everything is focused on the medicine and the procedures. Very little is focused on the care and handling. So it's very possible that the physician may have developed some bad habits or just learned some bad habits from whoever trained them, and they may be doing those things that result in additional damage to the devices. Now, this is one of the great things about an audit process. As you're observing that physician during the procedure, if you notice things that are functionality problems, performance issues that the physician didn't notice or didn't say anything about, or if you notice those improper use and handling, such as over torquing the knobs or resting the control body sort of on the bed during the procedure, causing that really sharp angle that you see on the right-hand picture, you really don't want to try and have that conversation with the physician right there during the procedure at the bedside. That's just a bad idea. That physician is focused on the patient. They're focused on the procedure. They're looking for whatever it is they're looking for. It could be cancer, for example. Their focus has to be entirely on that. And that's a terrible time to pipe up and say, "Excuse me, Dr. So-and-so, did you know that you're holding that scope entirely wrong?" That's just not a smart idea. And that's a great way to get yelled at and kicked out of a room very quickly, and for very good reason. But if you are auditing and making notes of these things, that allows you to have the conversation at a later point, like maybe after all the cases for the day are done. Or perhaps if you're not comfortable approaching that physician directly yourself, you can hand those observations off to an administrator and say, "Hey, we're doing an audit process to improve some of our processes. And, we're working through all the possible causes, and we've seen some things that maybe the physician is doing and could improve. Would you mind having that conversation?" Maybe you can talk to him about how much we spend on flexible scope repairs and how that affects their day and their surgery schedule. That's a conversation that an administrator can have. And when you've got that written in an audit tool, it allows for timing the conversation in a much better way that's going to be better received by the physician than trying to correct them at that point where they're actually working on a patient. Now, pre-cleaning is an incredibly critical time for infection control practices when it comes to flexible scopes. Pre-cleaning has to be initiated immediately after the procedure. And one of the most common places we see this mistake being made is in double procedures, where they do an upper and a lower examination. And so they'll usually do the upper procedure first. And so that scope that's used for the EGD, that one will get laid to the side for the duration of the procedure. And then staff will try pre-cleaning both at the same time after the lower is completed. The problem with that is that scope, and along with whatever bioburden is trapped inside those channels, may end up sitting there horizontally in the scope for upwards of an hour while the other half of the procedure is completed. Now, some of those bioburdens, like mucus, for example, can start to dry within minutes. And that's where a lot of your clogged air water nozzles come from, for example. So pre-cleaning has to be initiated immediately after the procedure. And the specific steps for pre-cleaning are going to vary slightly based on the exact manufacturer and model number of your scope. But generally speaking, you need to see the exterior wiped with a lint-free cloth or sponge. And we need to see clean water aspirated using that high pressure button if this is an Olympus scope. And again, generally the rule is 30 seconds in of water, 10 seconds of air. Now, there may be more or less depending upon who your manufacturer is and what specific model they're using. So for example, if this is after a ERCP procedure, there's going to be separate information that's specific to that model of scope. So make sure you know what those specific instructions for pre-cleaning are and that you are following them every single time. If you do not, we have seen a number of outbreaks associated with improperly reprocessed scopes. And back to that air water nozzle, for example, anytime you see a clogged air water nozzle, it's almost always caused by poor point of use cleaning practices. After the procedure, if your physician has used the angulation locks, you want to make sure that those are in the free position. You can see on those examples there, you see an F with an arrow pointing. F is for free, and you want to make sure those locks are in the free position. If they are not released, the scope is actually resisting any movement to the angulation system, and it will still move if you move those knobs, but it's kind of like driving with your parking brake on. Like, yeah, if you give it enough gas, your car will still go, but you're burning your brake up in the process. Same kind of concept. If you're reprocessing your scope with those angulation locks engaged, that distal tip will still move, but you're stretching out your angulation wires in the process. So you're going to see much increase in how much wear and tear your angulation system is taking if you are not putting those locks in the free position every single time as the reprocessing is initiated. And then of course, again, same thing with the tensioner knob. You want to make sure that tensioner knob is in the most free position during the reprocessing phase if your physician has made use of that tensioner. Now, transportation, in my opinion, is one of the biggest opportunities facilities face for improving their preventable damage. Very frequently, we see scopes that are being transported, like the top example, where they're in a bag. And from an infection prevention standpoint, that bag is acceptable because it's sealed and it protects the scope from the outside environment and protects the outside environment from the scope itself. So, it's very easy in a compliance audit to miss that. This is, although in one sense okay, but from a damage prevention sense, this is terrible. Every bit of weight of that scope is kind of collapsing down on itself when it's transported like this. There's no support given to it, and this is absolutely what's going to cause the light guide connector to ram into the distal tip where that very sensitive bending rubber is. That's where your holes very frequently come from. And because it's being wrapped up very tightly and there's no support given to it, that angulation system is just getting stretched out like crazy. By far the best practice for preventing damage to scopes is a rigid bottom container that gives the scope some support. And I really like this example in the bottom right hand corner there because this facility has even taken their sponge from the pre-cleaning and left it on the distal tip during transport just to give it a little extra cushioning in case something does bump into it. Now, that's not required by any means, but I do think it's a good idea because it's doing something to help prevent damage to that very vulnerable distal tip, which is also the most expensive area of the scope as well. So anything you can do to protect that, I think is going to be beneficial. Another mistake that we see facilities making very frequently is putting more than one scope in a container. Now, that is not okay from a compliance standpoint, but it will lead to additional damage as well because now you've got two light guide connectors floating around along with two of the really expensive distal tips. You've just doubled your risk for damage, and you've also created an environment where cross-contamination is very likely. So again, do not ever put more than one scope in a container, one container for one scope. Now, I do want to say that this is an important point though, because if you are using multiple scopes for a single procedure, such as the double that we just talked about, we have to be mindful of the fact that somebody has to transport those scopes then from the procedure room to decontamination. And if we are giving them more than one transportation container, they're going to have a hard time carrying that without stacking them. So really think through this. Think about what the challenges are to doing this correctly, and that's going to help you identify what the best practice for your facility is going to become. Now, leak testing is critically important for both patient safety and for preventing expensive damage. Fluid invasion is one of the most expensive types of damage, and it is almost entirely preventable through proper care and handling and leak testing. Leak testing must be performed on every single scope, every single time. And we have to make sure that the leak tester itself is working properly. We have had, on occasion, facilities who say that they leak test every single time and they keep getting fluid invasion. And we go in and we check the leak tester and it turns out their hose had a puncture in it. Your leak tester is not going to find any holes if it's not pushing air. So make sure that your tester is functioning properly. We also want to see proper leak testing technique used. And again, the specific steps will be lined out for you in those manufacturer's IFUs and may be slightly different depending upon what manufacturer and model you're using. But the general rules are going to be that the leak tester has to be attached and detached while the scope is dry. If you unplug the leak tester while the scope is submerged, you will flood your scope. We want to see at least 30 seconds of observation underwater, and you need to manipulate those switches and those knobs to see if maybe the way a scope is laying might be hiding a crack or a leak. This is also a great time to test your angulation to see if you've got that play in the knobs that indicates that your wires are starting to get stretched out. And then after the leak test, we also want to see that the scope is being depressurized, or commonly called burping. Now, depending upon who your leak test manufacturer is, your leak tester may do the depressurizing or the burping itself. But again, you have to know your manufacturer's instructions for both the scope and the leak tester before you can make those determinations. Now, once the scope has been leak tested, this is when you're going to do your manual clean. And it's very important that you have some form of lighted magnification for examining the scope during the manual clean process. A lot of areas, including that distal tip where there's a lot going on, they're very small, and tiny imperfections can make a difference in that scope's performance. In some cases, you can even find lights that are busted that aren't going to be providing the amount of light that a physician needs. And if you can't physically see that without lighted magnification, you will not know that that has occurred. Having that ability to see those things clearly is critical for finding things early before they affect a patient. We also want to see enzymatic being dispensed into the sink according to the IFUs of that enzymatic. I remember starting back when I was a technician, and the only training I received on enzymatic was, I was told this is the stuff that gets the scope clean. So, of course, in my mind, as a young technician, I thought, okay, well, if this is the stuff that gets the scope clean, then that means more is better, right? More means it gets more clean. And it turns out for enzymatic, that is patently false. That is just absolutely not true. If you are not dispensing enzymatic according to those IFUs, you are going to end up with residue left behind on the scopes. Enzymatic is very sticky. It takes physical effort to actually get the enzymatic off of the scope. And you can find scopes even that the lettering on it is kind of changed from that nice crisp white color to sort of like a dingy yellow or brown. And that's an indication that the enzymatic is not getting completely wiped off of the scope during the cleaning process. And that's not to mention that using too much enzymatic is also a massive waste of money too. So you need to know what your mixture ratios are. And if you're using an automatic dispenser, that has to be calibrated regularly. So partner with your provider of enzymatic and find out what those mixture ratios are supposed to be. And if you're using an automatic doser, how often that doser is being calibrated. Now, also during this process, the scope has to be handled delicately. That means not dropping it into the sink, not accidentally banging it against the sink side, no kinking, no wrapping it up very tight. It's very easy to make these mistakes as a reprocessing technician and not realize it. So again, this is a great advantage of having somebody who is auditing this process, because they can watch and see when mistakes are happening that the actual person performing the reprocessing may not even be aware of. Because if you tell the reprocessing technician, hey, don't drop the scope into the sink, hey, don't hit it against the sink side, they're going to say, well, of course I know that. That's common knowledge. That's basic. You should know not to do that. But what they may not be realizing is, as they're so focused on cleaning the scope, or if they're getting a lot of pressure from the OR to hurry up or get this reprocessed, they may not realize that they're making some of these mistakes. Now, as we move the scope from the manual clean into the AER, we want to make sure that we're handling it correctly. We're not bunching it up into one hand, that we're carrying it with the distal tip separated from that light guide connector, and we're holding it with two hands with no sharp angles. We want to make sure that we're loading it and unloading it correctly, because a lot of the same principles that we talked about in the transportation section still apply to this loading and unloading in the AER. So there's a lot of opportunity here for the prevention of damage just by simply making sure that we're doing it properly. We also want to make sure we've got the proper chemicals in use. This will be, again, be defined for you by your IFUs. This is not something we get to make it up as we go. We need to make sure that our scope is approved for whatever specific high-level disinfection or sterilization method that we are using. If you deviate from that, not only are you getting an unproven result from the high-level disinfection or sterilization process, but you're also very likely to see much more rapid damage being done to the device. Now, a quick word about sterilization, particularly for small diameter scopes like cystoscopes or your ureteroscopes. Always make sure that ETO cap is in place. I really wish they would call it something besides ETO cap, because you've got to use it even if you're not using ETO, if you're using hydrogen peroxide, for example, which I suspect most people are. But that cap still has to be in place. And the reason for that is because the first thing your sterilizer does in the sterilization process is it sucks all the air out of that chamber, which creates this incredible vacuum. Now, if there is air trapped inside that scope, that air will violently want to get out. And that's what you see on the right-hand side of the screen there. This was a scope that was put into a sterilization chamber without the cap in place. And that air, if it can't find a way out, it will make its own way out. And that's what you see when you see that blown tip. All of that could have been prevented simply by making sure that cap was in place before the scope goes into the sterilizer. Now, if you're using a different container than what the scope came in, I've seen many facilities go from sort of the OEM supplied plastic containers to a more rigid container. That's totally fine. You just need to make sure that that scope is still secured properly inside that basket and in a way that doesn't cause it to kink up or coil too tightly. If you don't have the scope secured in a proper way, the scope will slide around during the transportation process. I know I've seen many technicians, as they're pulling for cases, they are in a hurry, they're moving quickly, and they tend to pull those containers off the shelf very quickly. And if that scope is not held in place tightly, that scope is just getting banged around left and right inside that container. So again, that's going to be a lot of damage that could have been prevented just simply by making sure that the scope is secured properly inside the container. Now, like we said, we want to make sure that the scope can be transported to and from the automatic endoscope reprocessor properly. That means two hands. And when we hang it in the cabinet, we want to make sure that it's still in its most free position. So make sure that angulation locks are still in the free position. The tensioner is still in its most free position. Anytime you see scopes that are kind of hanging with curled tips, or maybe even seeing what we call snaking, where that insertion tube kind of bends back and forth on its way down, that's an early warning sign that your scope has something going on inside of it. Even if the OR hasn't complained yet, even if the doctor hasn't complained yet, that is telling you this scope is in danger. It's about to break at some point in the near future. So if you see that snaking, you know you've got a problem, and you know that you need to go ahead and get those scopes sent out as quickly as possible. Another mistake we see facilities making is not having adequate storage for the number of scopes they have. So what that means is that scopes can be placed in or then removed from the storage without banging into other scopes. That light guide connector that's hanging off of most scopes, particularly large diameter Olympus scopes, that light guide connector weighs as much as an ortho mallet. And it hangs just perfectly lined up to hit that distal tip where everything is so expensive to repair. And so if you find that technicians have to kind of move scopes out of the way, or even if they're just very quickly putting scopes in, sometimes that light guide connector will then begin swinging around. And I promise you, everybody knows you do not want an ortho mallet swinging around inside your flexible scope storage cabinet. But you already do have an ortho mallet swinging around inside your storage cabinet. It's the light guide connector. And so if you bump into it, if you're putting it in too quickly, it's potentially slamming into those distal tips and doing crush damage. Depending upon what part hits the bending rubber area, it could be leading to punctures. And all of that is going to lead to some very expensive repairs. And I promise you the repairs will be more expensive than it would have cost to just make sure you have an adequate amount of storage in the first place. So look at your storage, watch people load scopes in and take scopes out. Do they bump into other scopes? Do the light guide connectors go swinging around? Is it banging into other scopes? If so, you might need more storage. And a very important detail, and it really gets at the heart of what we're talking about with this process improvement project, is you want to make sure that there are an adequate number of scopes for the number of procedures that are being performed. I think that if I were to poll every hospital in the country about whether or not the technicians feel like they have enough scopes for the procedures that are being performed, the vast majority would say, no, we don't have enough scopes for the procedures that we're doing. And it's really easy to see how we would get to that conclusion. Scopes are expensive. New scopes cost anywhere from $25,000 to $35,000. So it makes sense that hospitals would try and get by with as few as possible. Now, the problem with that, though, is that like a survey that was conducted by Ofsted & Associates and Isham has found that 70% of reprocessing technicians are under pressure to go faster when reprocessing scopes. So they feel rushed. And in other words, they feel stressed out when it comes to reprocessing scopes. Now, like I've made mention of a couple of times already, that stress will lead to the additional likelihood of making mistakes. In fact, there's actually some metrics on this that are specific to the airline industry, but I think the same probably carries over and is true in a lot of industries, where they have found that if a normal human being does a well understood task 100 times, they will make about one mistake per 100 opportunities. So not a lot. But if you add stress to the mix, that 1 in 100 becomes 1 in 10. So you see literally 10 times a higher likelihood of making a mistake when you put somebody under stress. And we see right there on that survey, 70% of reprocessing technicians feel that they are under stress, they are under pressure to hurry up, go faster, because they don't have enough scopes to handle the amount of procedures. Now think about that. The average flexible endoscope reprocessing from beginning to end, if we count every single little step, totals up to about 120 to 130 steps. So that means that on average, if you're under stress, you could be potentially making 12 to 13 errors per time that scope is reprocessed. And the more opportunities we have for making mistakes, the higher likelihood that those mistakes are leading to damage and leading to risk to our patients. So saving money by buying less scopes makes sense on the offset, but you will end up paying more in the long run in terms of repairs and stress to your staff and potential patient complications. Now, it's really easy to just say, well, why don't you just buy more scopes? But the reality is most hospitals just simply don't have the budget. So where do you find the money to be able to buy more scopes so that you don't have to feel so under pressure in reprocessing scopes? Well, I'm glad you asked, because that's what we're going to be looking at now in the process improvement method. Now, we're going to use a Lean Six Sigma method called DMAIC, and we're going to use a very simplified system. It's not going to be really complicated at all, I promise. Don't let any of that terminology scare you. DMAIC just simply lines out the steps for you: define, measure, analyze, improve, and then control. We're going to go through each of those steps. And one of the things I really want to encourage you to do is, as you undergo this process, document what you've done. Just make a single PowerPoint slide for every little step that you did. And if you present that to an administrator, this is the language they speak. This is the things that they've been trained on, the ideas that are going to resonate with them. it can result in really building you up individually and your department up in the eyes of the administrators as being very professional and very process driven. So I really want to encourage you to follow this process and then document what you're doing, because it's going to help you communicate the value that you're bringing to a facility. So let's go through this step by step. Now, I said that D stands for define. So the first thing we want to talk about is, what is our problem that we're trying to fix? Best way to do this is talk to whoever your repair company is and get a baseline for how much you are spending on your flexible scope repairs. Your repair company, regardless of who you're using, should be able to get you this information very quickly. The next thing you want to do is determine how many procedures are using flexible scopes in an average day or week. Now, depending upon the size of your facility, it may make more sense to do average per day. If you're a smaller facility, it may make more sense to do average per week. You're going to have to make that determination on your own. But the thing I really want to emphasize is, very frequently when we're talking about audits, the first thing people want to know is, what's the least number I can do to get by? And that's a bad attitude. The more audits you do, the more accurate results you're going to get. So I really want to encourage you that you want to do a lot of these, and you want to do them regularly so that you can get that good representative sample of what's going on with your process. So if we were to work through an example of what the define process would look like, we've called up our repair company and we have found out that we spent $100,000 on repairs last year. Now, that's actually a relatively small number. A lot of facilities are spending $100,000 a month. But let's just say, for the sake of argument, we've spent $100,000 last year on our repairs. Like I said, 80% is preventable. That means 20% is regular care and maintenance, meaning even if everybody is doing their job perfectly, nobody makes any mistakes, there's still about 20% that you're going to spend no matter what. A good way to think about this is kind of like when you buy a car, you understand that by driving that car, you're going to have to get the oil changed occasionally. You're going to have to get the air filter changed occasionally. You're going to have to change the tires occasionally. The only way to prevent that is don't own the car. The only way to prevent regular care and maintenance, that 20% expense, is to just don't own flexible scopes. But that doesn't help anybody, right? So no matter what you do, you're going to end up spending some money on regular care and maintenance. So if we subtract that regular care and maintenance from our total opportunity, we get what our savings opportunity is, which, we're using nice round numbers to make it easy to kind of go with. So 100,000 minus 20,000 is 80,000. We have 80,000 in opportunities. So we might kind of define our project just like this. Last year, our facility spent $100,000 on flexible scope repairs, and as much as 80% of that is considered preventable. Therefore, our project is going to seek to identify the sources of preventable damage so that we can reduce the overall spend on flex scope repairs. That's a good 2-sentence statement. Even if you're an administrator and you have no idea what's going on in flexible scope reprocessing, you can understand exactly what this project is about. Now, the next thing we want to do is measure, and that's what this audit form is for. Perform your audits. Again, remember, more audits, more accurate results. And these audits are going to tell you how many procedures you're seeing an error rate in and where that error rate is happening. So for example, if you observe 10 procedures and you find errors in 3 of them, you've got a 30% defect rate. Now, don't be surprised if you find errors in 10 out of 10 procedures, because part of what we're going to do next is determine where our efforts are going to be best spent. But we have to have a starting point of understanding how many mistakes we're making per reprocess. This is where our data becomes really important, and this is where we get to be really creative. This is the analyze phase. So now we're going to look at all of our audits, and we're going to determine what areas we really want to focus on. One of my favorite sayings in process improvement is, if everything is a priority, then nothing is actually a priority. And I'll let you in on a little secret. This is why generic care and handling in services don't fix any problems, because they're about everything. Now, they're really great for sort of having a baseline, getting everybody up to kind of on the same page. But the problem is that you can't target everything for improvement. It just simply doesn't work that way. Instead, what we want to do is we want to find the areas that we can focus on first. Now, a few little guidelines that will help you are, obviously, we're looking for the areas that are the most frequent areas of failure. We also want to look for things that are the most expensive areas of failure. So, for example, if you find in your analysis that maybe a small percentage of times, maybe you've got one technician who isn't leak testing every single time. You don't have to do a general care and handling presentation for that. You might want to just have a conversation with that specific technician, because that's an expensive area of failure. It may not pop as being a common one, but it's an expensive one, and just improving that one may have a great result. So, if you find those areas that are really expensive, you might want to focus on those. Another one that kind of gets missed sometimes is the easiest areas to implement change. Nobody really likes change. So if you've got maybe staff that aren't 100% bought into your project, or maybe physicians, for example, who aren't really bought into your project, if you can find a few easy wins to get that quick support, that's a good way to kind of snowball into much more dramatic changes. So again, think about the physician damage. If you can demonstrate to the physicians that, we've made some changes, here's the results we've seen, can you help us out and do this for us? That's going to have a little bit more effect than just saying, hey doc, this is all your fault, change everything. This is an actual preventable damage project that we helped a customer with. And this is an unusual one, but I like it because it does highlight why it makes sense to focus in on just a couple of things. Generally speaking, you're not going to want to focus on more than about 3 opportunities at a time. After that, things get way too spread out. Now, this facility was doing a great job in a number of areas, but there were a couple of areas that really just stood out as, wow, we need to make a few changes in just a couple of spots and it will have a huge difference. All I did on this was I simply laid out all the steps in the audit on an Excel spreadsheet and then marked what the percentage of failure was for those and laid them out in what's called a Pareto chart. And actually, if you lay out the damage prevention audit form into an Excel spreadsheet and say, here's the percentage of errors, and go to analyze data in your Excel spreadsheet, the first thing that will pop up is a Pareto chart, because that's the way that it's designed to function. And what a Pareto chart does is it kind of helps you focus on what are the areas for greatest opportunity. And sure enough, this facility, 100% of the time, they were failing in transporting the scope properly. There were a couple of other opportunities that were easy wins in there as well. But you can see how laying that out into sort of a chart kind of helps define where your efforts need to be in the first place. So once we've identified where our efforts need to be focused, now we can focus on how we're going to improve those things. Now, this again is an opportunity to be very creative. This is an opportunity to involve a lot of key stakeholders, because the exact improvement method you take may not be the same for everything. And it probably is going to vary even from facility to facility. Look at where the opportunities are and then determine what are the best ways of approaching that. It may be education. Like, for example, the example I used where it was one technician out of maybe a dozen that just wasn't leak testing. Educate that specific technician. It may be education that needs to be delivered to specific groups. So, for example, you may have different transporters who are taking the scopes from the OR to the reprocessing area. Well, you can deliver care and handling in services to the OR and to reprocessing all day long and not fix that problem. So it might help you target specific groups. Maybe it's a weekend group. Maybe it's the third shift. Maybe it's first shift. But it allows you to target that specific group with education that is going to speak to those problems. Now, in some cases, it might require investment in new products or infrastructure. For example, more storage cabinets. These are the things that, it really helps to have these things lined out for an administrator so that they can see the opportunity for savings. But again, brainstorm, be creative, involve those key stakeholders, help them understand what the opportunity here is, and then test those solutions. Not everything may work. Some things might be really obvious. Some things might take some experimentation. Test those solutions, measure your progress, and then see what works best. And then the final step is control. And I also like to say that the final step, C, also stands for culture. Because if a process improvement doesn't make it into the culture, meaning the way that your staff always does things, then it's never going to stick. You're going to see improvements for a month, 2 months, and then something's going to change and everybody's going to go back to the way it was before. Controlling is about changing the culture of your team. We want to integrate those successful solutions into your normal processes. Obviously that's going to require updating your policies and procedures. A good way to kind of get buy-in is to involve those key stakeholders in the rollout. Train your new staff for compliance so that they're being trained from the beginning to do things the right way. And remember, culture always wins. And something I just cannot emphasize enough is when you've completed this project and you can demonstrate those successes, man, report those to your administrators. Let them see what you're doing. I promise you it's going to build you up and it's going to build your staff up to those administrators, and you're going to find yourself being somebody that they look up to and respect. So let's go back to our example. Let's say our audit tool has revealed that we have a 50% failure rate. That's kind of our baseline failure. Now, after we've gone through this process, we've re-audited to see where we are, and we have found that our new failure rate is 30%. And I know that there are people, when they see that, they're saying, oh, are you kidding me? We went through all these steps and all we see is a 20% improvement. No, actually, you're seeing an improvement of almost half. And what that means when we put that into dollars is actually pretty astounding. So we know that how much we were spending for preventable costs based on our previous 50% failure rate, it was $80,000. And if we improve that to $30,000, well, guess what? That's now $48,000 in preventable costs. So if 50% equals $80,000, that 30% rate should only equal $48,000 in preventable cost. That's an improvement of $32,000. So what you can do then is take that money and then reinvest it into things that you need. Maybe those infrastructure improvements that we were just talking about. Just to give you an idea of what $32,000 can look like, what can you do with $32,000? Well, you can buy 5 small diameter flexible scopes. You could buy 2 large diameter flexible scopes. You could buy 21 rigid laparoscopes. You could buy 13 surgical power tools. You could buy 10 video cameras, or you could have the world's most banging pizza party. You could buy 5,342 Little Caesars hot and ready pizzas, and that does not include tip. And I would highly recommend that if you do buy 5,342 pizzas from your local Little Caesars, you will definitely want to leave them a nice tip. So keep that in mind. But the point is this. All that money that we said we never have, we don't have the opportunity to improve things because it's just not in the budget. Well, it is in the budget. It's just tied up in things that we shouldn't be spending it on in the first place, like preventable damage. And so if you can find a way to improve your processes using these forms, and then use them to target specific things to improve, you will find that that results in having more money to spend on things that you can use to improve your department, like more equipment, for example. So in conclusion, most damage to devices occurs as part of its use and procedures and the reprocessing cycle. Now, regular auditing is an important tool that can help you identify sources of damage to devices. Process improvement projects can have a demonstrable return on investment, and those key three letters that's the language of the administrators. ROI, return on investment. When you can demonstrate that your projects are having a return on investment, you will see more money appear in your budget. And the money that you're saving on that preventable damage, you can then turn it around and reinvest it into a number of valuable improvements for your department, including having a really banging pizza party. So this concludes our presentation on Save Money, Save Stress, Auditing to Prevent Damage to Surgical Devices. I hope that you've learned a lot, and I hope that you will use our damage prevention audit forms as a tool to help you improve your processes and save that money and just avoid stress that you just don't have to deal with. You have enough stress in your life already. Your jobs are incredibly stressful, and if we can do anything to alleviate that stress, I want to encourage everybody to take part in that. I also want to conclude just by simply saying thank you for everything you do. It is our pleasure at Northfield Medical to serve you in the medical community, and if there's anything that we can do for you, please don't hesitate to ask. We really appreciate you, and we want to be your partner. Thank you again for attending this presentation.